Okay, so welcome and perhaps welcome back to all of those who are tuning into this session as part of ISNTD Water, our annual meeting on all things WASH, water, sanitation, hygiene, and global health. We've already had a really packed day. I think what has shown through our 3 sessions today has been the scope and breadth of collaborations needed to really drive forward these all-important global goals, whether they be in WASH, whether they be in tropical health, and also we've heard some really fantastic and inspiring concrete and practical examples of the sorts of partnerships that are needed. So we're now coming to the 4th session of the day, and we'll be focusing on the H in WASH, looking at the hygiene element and how that links to the diseases of the world's poorest and of neglected communities. It's really sad when something is even more neglected than neglected tropical diseases, and it seems that at least historically, global oral health has had that fate. This year has been really exciting on a number of levels. You may recall at WHA this year there was a historic resolution endorsed by a vast majority of the member states on pushing oral health right up the global health agenda. So there's a lot of momentum now growing in this field. There's been a recent Lancet commission on oral health. They've launched a series on this topic. So we should watch this space. So today we're going to take a closer look at the history of global oral health, where this is going, the partnerships involved, and also why this is such an important and crucial partner in tackling neglected tropical diseases. And to unpack and look at all of these issues, it's our supreme honor and our pleasure to welcome 3 partners, 3 colleagues who have been working tirelessly in this field basically for decades. Today we stand on the shoulder of giants who've been advocating for global oral health for a long, long time. And it's my greatest pleasure to welcome today our 3 speakers. We're going to hear from Dr. Habib Benzian. Dr. Habib, you're from the NYU, the New York University College of Dentistry. You're co-director there of the WHO Collaborating Center for Quality Improvement and Evidence-Based Dentistry, and you're also part of the Lancet Commission on Global Oral Health. We'll also have the pleasure of hearing from Dr. Yuka Makino. Dr. Yuka, you're Technical Officer for Oral Health at the WHO Regional Office for Africa, and you're tuning in from Brazzaville today. And finally, we'll hear from Dr. Joel Rosenbloom. Dr. Joel, welcome. You're calling in from the University of Toronto's Faculty of Dentistry. You're also director of the Faculty of Dentistry's program, the Toronto Addis Ababa Academic Collaboration. You're also, and very interestingly, staff dentist at the Center for Addiction and Mental Health, and I'm sure you'll tell us a little bit more about that. At this point, I'd like to invite Dr. Habib Benzian to give us a presentation, and Dr. Habib, you'll be giving us an overview of oral health, NTDs and WASH, and why right now there's a new global momentum as well as the opportunities for integration.
Thank you for the introduction, Marian, and welcome to everyone who is hanging in there after a long day of webinars. I admire your stamina, but I'm grateful that you stay on for this topic of oral health. And I'm really grateful for Marian and your society for taking this topic on your agenda. We, of course, oh, there's my video coming back. All right. Of course, it's a great opportunity to explore the intersectoral aspects between oral health, neglected tropical diseases, and WASH at this point in time, because a lot is happening, as Marian already indicated and Joel also mentioned. My talk is, as Marian said already, focusing on the other end of the spectrum, while Joel was talking a lot about grassroots, local initiatives on the ground at the clinical end, and also, of course, at the local advocacy end. my talk is more on the global issues. I've been working in global oral health for the last 20 years. So I will go back in history a little bit, but also look at the present and the future. The outline, what I'm going to talk about. First, I would like to speak a little bit of on the question whether oral health is actually a neglected issue in global health. I will share a little bit of the oral health status currently on a global international level. And I will share some details around this policy momentum in global health that is unfolding at the moment, before moving on to the links between WASH and perhaps One Health as a topic that you have also explored today in your conference. And I will close with a very practical example of a school health program that combines WASH, neglected tropical disease, and oral health in a very comprehensive and simple way. So the key question that we have been grappling with as an oral health community is, are oral diseases neglected? And is oral health a neglected area of global health? Of course, as a neglected tropical disease community, the term neglected implies many things. If we look at this word neglected from an oral health perspective, we may associate different terms and we have different connotations to this word. About half of the world's population is actually suffering from one or several oral diseases. And my key question is then, we talk of a neglected disease when it affects so many people, because oftentimes the label of neglected disease is also associated with of people being affected, so orphan diseases. So the story of oral health is not only one of high numbers, but it's also one of massive inequalities. And that is the key headline throughout. Inequalities in terms of disease burden. About 3/4 of the disease burden is actually with people living in low and middle income countries. Only 16% of the global disease burden is in high income countries. And the main diseases are caries, tooth decay, or sometimes just called cavities, severe periodontal disease, sometimes called just gum disease, toothlessness, in the technical term edentulysm, which is a quite debilitating condition for people because they cannot chew, they have difficulty speaking, socializing, and everything that you do normally with your full dentition. Of course, lip and oral cavities, who are major, who have a major mortality also, and are a key problem for oral surgery, for maxillofacial surgery, particularly in health systems where surgery services are not available or are weak. Another area of inequality is very clearly the differences in dental expenditure from health systems, but also private expenditure. The long bars at the bottom, those are the high income countries which spend about $300 billion per year on dental health care. Per capita, that's about $270 per person. And then look at the other bars for the upper middle, the lower middle income countries, and the low income countries. The low income countries virtually spend nothing on oral health. The actual expenditure per capita is around 50 cents or less per person. Imagine what type of services you can make available for 50 cents per person per year. So there's a massive, massive inequality in terms of expenditure, which of course reflects also the availability of services. Another area of inequality is the health system capacity. Here you see the ratio of oral health professionals per 10,000 population. High income countries have about 20 times more oral health professionals per 100,000 than low income countries. Only 1.5% of dentists worldwide are working in low income countries. When you put that together with the disease burden that we saw earlier on, the high income countries have about 20% of the disease burden, but they have 80% of dentists. So you see inequalities and differences between countries, income groups, and of course, all the populations that live there are really stark. All of this leads to the situation where we estimate that about 4 billion people have never seen a dentist or have difficulty accessing a dentist on a sustainable and affordable basis. So about 4 million people are lacking access to oral health care, even essential oral health care services. And that leads, of course, to universal coverage cannot be complete without including oral health care, essential oral health care, and access for everyone. We need to take into account that oral diseases are not just a problem of the mouth. They have huge impacts on general health, on individuals and the way they live, they socialize, they can be productive, and of course on societies as a whole. The productivity losses from dental diseases are massive. They are about the same amount as the direct expenditure, so around 300 billion, a bit less. But estimations in this area are definitely very complicated and difficult. So oral diseases are not just a problem of the mouth. They are a problem of the entire person, of general health, and of societies as a whole. All oral diseases share common risk factors with other diseases, and mainly, first and foremost, of course, with non-communicable diseases, the NTDs. And those risk factors are the classic ones: tobacco, alcohol, injuries, diet, but also hygiene, that is circled in red on the left side. Hygiene in the sense, of course, of oral hygiene, but there are also links with the wider wash, sanitation, and environmental hygiene area. Again, the question, is oral health neglected? Looking at prevalence from 1990 to 2019, global prevalence rates have not changed a lot. They have been basically stable throughout these 30 years. We have this information from the Global Burden of Disease Project's estimations, which include all oral diseases. So a stable prevalence, no decrease. And at the same time, we have about 1 billion people more affected by oral disease. Please note, it's billion. 1 billion people is a really massive number. In the same time span of 30 years, have been added with oral problems. Of course, they are presenting a massive challenge for health systems. And when you remember that the disease burden is mainly in middle-income countries, many of, particularly the low-middle-income countries, have fragile health systems still, or health systems that do not cover everything, or they are not available to all populations. So the burden of oral diseases is particularly severe and challenging health systems in middle and low income countries. That was one of the starting points for the Lancet series, and this is a statement taken from the Lancet series that oral health can no longer be left behind and requires urgent and decisive action. I think when you keep these numbers in mind and these facts, you will certainly agree to that. It was already in 2007, so a long time ago, in global health terms. This is like ancient already. The Director General at the time, Dr. Margaret Chan, on the occasion of the adoption of a resolution on oral health, she said that oral diseases are neglected, a neglected area of international health. She also said that the tools and practices are available to address them, but we need to ensure that they are applied and implemented. And I think this is still a very relevant and very pertinent statement. So again, are oral diseases neglected? I think yes, but the neglect is mainly political. And in order to overcome this political neglect and the low priority on political agendas and with decision makers, we have, of course, studied the neglected tropical diseases movement. and how it happened that NTDs were suddenly, or not suddenly, but they were gradually climbing up on the international health priority lists. Since this resolution in 2007, it has been kind of a fragmented journey for oral health, thanks to international advocacy of civil society organizations, of the profession, of the dental profession, of oral health professionals, of some dedicated governments, and a whole group of advocates working on different levels. So there were some milestones on that way towards the resolution that was passed this year. And one of the milestones is the political declaration of the high-level summit on universal health coverage that took place in 2019. The whole document is, I think, several dozen of pages, and it's just in one paragraph of this political declaration that oral health is mentioned, together with eye and other rare diseases and the neglected tropical diseases. All of these are meant to be part of universal health coverage. That is an important anchor for all advocacy that has happened since then. And we go back to this commitment by governments on a regular basis. The Lancet series I mentioned was a turning point and generated a lot of government and WHO action and paved the way for new policy initiatives. One of them is the resolution that Joelle and Marianne have already mentioned. It took place in several steps, a resolution at the Executive Board meeting in January this year and another one in May at World Health Assembly. So this is the first time since 2007 that oral health has been on the agenda of these two main governing bodies of the WHO. And the resolution was supported with was adopted with great support from WHO member states. And the decision was to develop a global strategy, an action plan and a monitoring framework to cover the next decade and to formulate goals and targets for 2030. On this occasion of the adoption, the Director General, Dr. Tedros, said that oral health has been overlooked for too long on the global health agenda. We need to make sure that oral health is repositioned as part of the global health agenda in the context of universal coverage. So there we have again all keywords, and we have yet another sad confirmation that oral health was neglected or still is neglected. But now we at least can see some light at the end of the tunnel towards a situation where we see less burden or better access to care and prevention, of course. WHO is now working on a global strategy. The adoption is anticipated for next year's World Health Assembly in May. The year after, a global action plan will be presented, including a monitoring framework with clear measurable indicators and targets. As Dr. Chan, the former WHO DG, said, what gets measured gets done. We are hoping for the same related to oral diseases, because so far, oral diseases are not part of routine surveillance in most countries. So if there are indicators and a monitoring framework, that means that governments can be held accountable with their progress towards the agreed goals. From other diseases, you may know the concept of best buys. So those are cost-effective, highly cost-effective interventions to address the most common needs. We have currently started the process of working on such best buys with a group of international experts and WHO collaborating centers. You may also have heard from the Minamata Convention on Mercury, which is aiming for the elimination of mercury. And there's one particular dental filling material, amalgam, that is supposed to be phased out. And countries need support in this process because amalgam is a relatively cost-effective, rather cheap filling material, but we need to find alternatives. Let me talk a little bit about the Fit for School program as an example for integration of WASH, neglected tropical disease, and oral health. It's reaching at the moment about 20 million children daily, mainly in Southeast Asia. A couple of countries are part of that program, and the governments are promoting it as the school health program in these places. It is structured in a very simple and modular way, uses evidence-based interventions that are very cost-effective, and it uses daily skills-based activities in schools. So it is not providing any health education approaches. It's supported and kickstarted by the German Development Corporation, GIZ, that some of you may be quite familiar with. The program actually is addressing very important determinants of health. You are probably all familiar with this classic diagram from Dahlgren. The key determinants of health: water, sanitation, healthcare services, education, just to name a few. They are important for all diseases, not only for oral health or for neglected tropical diseases. So what does the program do? The Fit for School program combines daily hand washing with soap. It's a daily activity and a group activity. You see, there are wash basins that can accommodate about 10 children with very simple water delivery systems, very water saving also for water scarce areas, and soap is provided. As we know, certain behaviors can only happen if the infrastructure and the supplies are provided, and hand washing is a great example for that. If there's no water, no hand washing. If there's no facility, no wash basin, difficult. If there's no soap, well, hand washing is less effective as an intervention. Toothbrushing is also part of the program. Toothbrushing with a fluoride toothpaste, it addresses tooth decay. Caries, as we've seen, is the most common childhood disease worldwide. Is a group activity again. The advantage of group activities is that many children can do it at the same time, which simplifies the logistics on the school level. It's easy to have an entire class do the hand washing and toothbrushing exercise within 5 to 10 minutes. And on top of that, biannual deworming, according to national guidelines or WHO guidelines where there are no national ones. So the teachers are providing the school-based deworming program, thereby strengthening whatever local deworming program is in place. We know that school-based delivery is very effective in reaching one of the key target groups for deworming, and we also know the impacts of intestinal soil-transmitted worm infections on children's health and education. I don't need to reiterate that this with an expert audience like you are. Recently, we have, with the increased attention to One Health, we have reframed the concept of the Fit for School program, and we have developed something that is framing school health as a One Health activity. Because if it covers water, sanitation, and hygiene in schools, of course you are improving the environment and the conditions in the school setting. If you are adding a deworming aspect, of course, you are tackling a key pathogen that attacks and affects child health. And adding the toothbrushing component is, of course, addressing a major health issue. So we believe that schools are settings where One Health as a concept can really come to life by addressing the overlaps between human health, environment, and animal health or pathogen area. Of course, in schools where school feeding programs are also offered, food safety and hygiene around eating, of course, plays a major role as well. One of the key principles of the program is to make it as simple as possible for those who are implementing the program. That means that the whole procurement system is streamlined into very simple packages where the supplies required for children per school year are packed together and can be procured in a very cost-effective way. So the soap, the toothbrush, the toothpaste, and the deworming drug costs about 50 cents per child and per year. In addition, of course, this is a very intersectoral collaborative effort between the education sector, because it happens in school. It should be under the leadership of the education sector. This is their turf, and schools are their premises, but they need the technical support from the health sector. And of course, when it comes to WASH, to any other line ministries that are in charge of WASH, like public works, public health, or infrastructure. And the program provides different tools for capacity building, to involve the school community, for teachers who are implementing the program, guidelines, manuals, films, etc., to make the program implementation as simple as possible. It should be noted really that the program is not employing any health professionals. Everything is done by teachers and by parents. Health professionals only come in when it comes to support, to technical advice, to training, but are not involved in the day-to-day activities. Just to finish my presentation, it's a plea for school health from Don Bundy, one of the lead experts at the time in school health. The question is not whether school health programs are necessary, but how they can be implemented at a meaningful scale in the poorest of countries which need the most. And I think this is very true for WASH. Definitely WASH in schools is an area that needs more attention worldwide. About half of schools do not have water and basic hygiene and sanitation services. And they are wonderful platforms for mass deworming programs. So controlling neglected tropical diseases, soil-transmitted helminth infections in schools is a great start. That's it for now. Thank you again for your attention and for bringing oral health on your NTD agenda.
Well, actually, we would like to thank you so much, Dr. Habib. That was, if I didn't have to moderate a webinar, I would probably stay speechless for a while. The level and the numbers, the scope and breadth of the problem that you described, but also some of the political backing that's been happening on a more positive note in recent times are both really impressive. And there's so many parallels with neglected tropical diseases that it's been really, really interesting to see a neglected aspect of health from a completely different lens. So thank you so much. And you've brought so much experience to this session. And you've been working, you mentioned the program that we heard all about, run by the teachers, the Fit for School approach, and with really focusing on the ease of implementation. That's been very impressive and informative, something we need to take on board. And you've kind of brought into this not just your experience as an oral surgeon, but also your level of your advisory kind of level at international organizations. So we're really honored and thankful to have heard you today. And we will definitely keep a close eye on what's happening in the oral health field now that we are more aware of the magnitude of the problem. So a very huge thank you.
Thank you, Marion. It's great to hear. And just one thing that really strikes me when looking at the movement for neglected tropical disease and how it increased over time. One of the starting points for this was to combine the numbers of the different neglected tropical diseases into one big figure that is very impressive. So there are small diseases with low numbers independently, but combining them makes a much more powerful statement. And we have learned from this by combining the oral diseases together into this 1 billion figure of increase over 30 years. And the current stark numbers, that is a massive change in the advocacy strategy that we have learned from you.
Well, I feel like I'm learning a lot from you today, so perhaps it should be more than a session, this kind of hand-in-hand journey. It should really be rolled out. And that's why what we wanted to do with this session is not just talk about oral health as a neglected condition as in oral health, but really to look at some very concrete linkages between oral health and actual diseases. So we did, there's as you can imagine, very little published in that way. A team in Brazil who's been looking at the linkages between oral manifestations in chikungunya patients, and that was very interesting to sort of see how the oral health profession and dentists in particular could look at one of these really understudied symptoms of chikungunya and how the two fields could collaborate. Another neglected disease that immediately springs to mind is the disease Noma, where a bacterial infection in the mouth rapidly becomes gangrenous and can have devastating effects. In 90% of cases, those who contract Noma are likely to be deceased within 2 weeks. It's a terrifying progression in the disease, and of those who do survive, unfortunately, are faced with really profoundly life-changing consequences, not just physically, but also in terms of mental health and stigma and all sorts of things. So on many levels, not just in advocacy, but also very pragmatically on a clinical level, we really felt that understanding a bit more and knowing a bit more about oral health was very important. And just coming back now a little bit to Noma specifically as an example of this, we've had the absolute pleasure to welcome Dr. Yuka Makino. Dr. Yuka, you've been tirelessly advocating for Noma, for oral health, and Noma's profile is raising slowly but surely. As you know, this is a cause that's very close to our hearts. There have been a few conferences organized now over the last year and a half. We've been involved in that. A huge number of partners have been involved in that. MSF in particular are leading the charge on raising the profile of Noma. And Yuka, it would be lovely for you to give us an overview of what happens when the oral health sector and the NTD sector work hand in hand.
Very much for invitation for this wonderful seminar. And as Professor Habib mentioned, that I also echo, we are very glad you keep the position for oral health, including Noma, for this WASH and NTD meeting. That is really, appreciate. So I start my presentation. So thank you very much for your kind invitation. Today, I'd like to talk about WHO Global and Regional Noma Control Program, integration of Noma into NTD and WASH programs. So this is Yuka Makino. I'm a focal point of oral health in WHO Regional Office for Africa. So this is the contents of today's presentation. So first of all, I'd like to review what is Noma. So as you see this slide, Noma is a necrotizing disease, destroy the mouth and the face. In the absence of treatment, Noma is estimated to be fatal in 90%. However, if Noma is detected early, the progression can be rapidly stopped. It mostly affects children between 2 and 6 years old suffering from malnutrition, living in extreme poverty, and with weakened immune system. Therefore, Noma is called the face of poverty. Because of the rapid progression and high mortality rate, numerous cases remain undetected. Now, mostly Noma is prevalent in sub-Saharan Africa. This slide shows the key milestone of global and regional Noma control program by WHO. Since the inception of WHO global program to control Noma in 1994, the WHO Oral Health Program has led global and regional Noma control effort, including, firstly, providing a strategic direction on Noma prevention and control, including facilitating the discussion on Noma in the WHO decision-making body. Secondly, the technical and financial support to develop and implement national Noma control program. Thirdly, producing the technical guidance document, and we also support the research on Noma. In these key milestones, today I'd like to highlight several key important issues such as regional Noma control program, systematic review of Noma, step-by-step guidance documents, as well as Professor Habib already mentioned that WHO Oral Health Resolution in 2021. So WHO Regional Office for Africa has supported 10 Noma priority countries, you can see the country name here, to develop and implement national Noma control activity, financially supported by German NGO Toothbrushing Noma since 2030. As you know, challenges for Noma prevention and control are potentially existence of broader determinants of Noma, for example, complex interaction in immunocompromised children with measles, malaria, or HIV. Also malnutrition, lack of vaccination in children, and poor oral hygiene, several social and environmental factors. Second point is both the general population and health workers do not know about Noma. Moreover, Noma is not integrated into the routine surveillance system, so it is quite challenging to know the epidemiological situation. Noma is linked with social stigma, which led to the hiding of affected children by their family, as well as made it very difficult to integrate Noma survivor and its family into the society. And we don't have enough evidence for epidemiology, etiology, pathogenesis, and also treatment efficacy of Noma yet. So in consultation with member states and experts, we developed the step-by-step guidance document to support Noma priority country to develop and implement national Noma program. Based on country context, country can select relevant objective and intervention. However, this step-by-step guidance document provides some specific objectives such as enhance integration, coordination, and leadership of the national Noma control program, strength and develop capacity at the primary care level and also community level for identification, prevention, and treatment of early stage of Noma. Moreover, undertake awareness raising and social mobilization campaign to improve public knowledge about Noma, contribute to the strength of health system, because as mentioned that the one of the problem in the Noma is the lack of data, therefore including the integration of Noma into the existing surveillance system is critical, and contribute to the reintegration of Noma survivor and their family into the society. And then final point is improve learning through monitoring, evaluation, and research. Indeed, WHO has encouraged countries to take more integrated approach for preventing and controlling Noma, because Noma are caused by a range of potential risk factors and underlying determinants. These are risk factors and determinants are actually shared by other conditions such as neglected tropical disease. To this sense, in whole specific objective, we can seek the possibility of integration of Noma into the NTD and WASH intervention, such as encouraging community health workers to integrate Noma or oral health activity into the NTD and WASH activity, or integration of Noma treatment into the skin NTD treatment. Another very important key milestone is already Professor Habib mentioned, that is Oral Health Resolution in 2021. In this May, during the World Health Assembly, it is a decision-making body of WHO, the Oral Health Resolution was proposed by 42 countries and discussed and endorsed. This resolution called on country action and also requests WHO action. Today, I'd like to emphasize the member states' namely country request to WHO in this resolution, especially related to Noma, which is highlighted in the orange box in this slide. As you see, member states requested WHO to include Noma in the upcoming review process for the WHO NTD list planned for 2023. As a result of this, Noma should be included in the roadmap for neglected tropical disease. What does it mean? Indeed, at the political level, it has been discussed that Noma should be included into the WHO NTD list because Noma affect vulnerable populations who do not have a political voice to advocate for this issue. In addition, integration of Noma into the WHO NTD list may help reverse the current situation, namely, Noma still benefit very limited attention by national health authority, research institution, and being neglected by international development and health agencies. So how to integrate Noma into the WHO NTD list and include Noma into the NTD roadmap? As I understand it, today, the most of the audience is coming from NTD team. Therefore, maybe you're already familiar with this process, but any inclusion of additional disease into the WHO NTD list should be requested by one or more member states and submitted to WHO NTD department. The request should be accompanied by dossier to justify how the disease meets the suggested criteria, such as disproportionately affect population living in poverty, primarily affect population living in tropical and subtropical area, amenable to broad control, elimination, or eradication by applying one or more of the 5 public health strategies, such as preventive chemotherapy, intensified case management, and safe water, sanitation, and hygiene. And then final criteria is neglected by research. Indeed, now WHO is conducting the gap analysis to demonstrate whether Noma meets the inclusion criteria of the WHO NTD list. As a part of this gap analysis, I'd like to introduce the summary of the result of a systematic review of the evidence-based knowledge on Noma jointly conducted by WHO and Infectious Disease Data Observatory. This systematic review actually includes 293 studies from 65 different countries between 1896 to 2019. This map captures the spatial distribution of Noma study from 65 different countries. According to this systematic review, 74% of the study were case report or case series, and only 5 interventional studies were identified. 190 unique potential risk factors were identified, and a total of 317 unique interventions were reported. But this indicates substantial heterogeneity in reported risk factor and intervention. Moreover, there was also a large variation in the quality of evidence provided by primary source in terms of estimate of incidence and prevalence reported. In terms of WASH-related issue, the risk factor of poor oral hygiene was identified in 54 studies. Some publications in this review mention physical environment factor, including unsafe water, and social economic factor, including lack of access to safe drinking water. However, little evidence reported across studies related to prevention of Noma or preventive therapy, including good oral hygiene practice. However, not included study assess the efficacy of any preventive intervention. Therefore, need more prospective interventional study and the standardization of the definition and diagnostic methodology, as well as standardized treatment guideline of Noma will be required. So this is a key take-home message from my presentation. Take a more integrated approach is required for Noma prevention and control, including integration of Noma into NTD or WASH interventions. Resolution of oral health provide a welcome opportunity to address the public health challenge posed by Noma as a part of the roadmap for NTD 2021 to 2030. One or more member states need to request including Noma in the planned WHO 2023 review process to consider the clarification of additional disease within the roadmap for NTD with a dossier. The current systematic review highlighted substantial knowledge gap and severe lack of high quality and comprehensive study. Therefore, the global Noma community needed to prioritize the documentation of its burden and delineation of effective strategy and intervention to prevent and control Noma. So thank you very much for your kind attention. Over to you, Marianne.
Yuka, thank you very, very much for your presentation. I think if some of us hadn't heard or didn't know fully about Noma. I think you've really inspired us to find out more. I'm going to be posting some links in the chat. For anyone, I would urge to take a few moments, take this opportunity to really learn about this devastating disease. There's resources on the MSF website, some more kind of traditionally clinical resources, but also if you are that way more inclined, a really beautiful film called Restoring Dignity and a shorter version called Surviving Noma, created by Claire Jantet and Fabrice Cantarini from ISNTD, a French company, that really charts beautifully the journey and the story of some Noma survivors. So I just really wanted to make sure that we had the opportunity to highlight Noma specifically as a devastating and neglected disease. I think we really owe that to the individuals and the communities who are at the mercy of Noma. So thank you for that. And Yuka and Habib, what was really inspiring from both your presentations, I think I've already said this, is this kind of very organic fit between where the oral health sector is at the moment, the level and the type of burden. And that really matches, I think, also the journey of the NTDs. Maybe there's a little differences here and there in terms of the years and the stages rising up the advocacy ladder, and not all the NTDs are at the same level either. But it's a really good to open up this forum, to open up this dialogue and to learn a lot more, because I'm sure many of us who don't know exactly the magnitude of the figures that we've heard about before, this huge burden of oral ill health. So thank you both very much for that. So what we wanted to do today is hear on the one hand about the advocacy around global oral health. We also want to hear about the journey of this neglected field through the official structures at WHO. And we also wanted to hear about some of the very concrete examples of partnership between the dentistry and oral health field, the WASH field in general, and the health of the most neglected communities. And so perhaps to hear a bit more about those concrete programs, I'll hand over to you, Joel, right away, and you can tell us about some of your extremely exciting programs that you've been working on over the past many years. You're also a very enthusiastic and great advocate for these issues. So it's my pleasure to hand over to you.
Thank you. First of all, I want to thank Marianne for inviting me to speak. I hope you find what I have to say interesting. And I just wanted to acknowledge that I am co-presenting with two people who I hold in very high regard. And I hope my presentation holds a candle to theirs. So I'll do my best. I'm going to screen share now. My presentation is more going to be, I've been asked to give examples of programs. And from my point of view, they're programs I've chosen that are designed to overcome barriers to access to oral health, and that form partnerships that work towards overcoming these barriers. This is an image, a historical image from 1920 from Beira, Mozambique. It's during colonial times. It's actually the hospital that I worked at from 1986 to 1989. It doesn't look like that anymore. This part has been rebuilt, but I just like the image because it probably shows from 1920 to now. There's been some things that have really moved in oral health, but there have been some things that really haven't changed that much. I'm going to touch on 5 different programs, 5 different examples of work that I've been involved in over the last numerous decades that really focus on bringing oral health a little bit more into the realm of accessibility to low-income populations, and that look towards partnerships with people. The first one is Center for Addiction and Mental Health, called CAMH. This is where I'm a part-time staff dentist there. It's the largest psychiatric hospital in Canada. And we have a small dental program. And the dental program has this unique place in dentistry. It's got this unique place in the hospital. I don't know of another program quite like this. It's a program that's actually right in the hospital, and it's only accessible to inpatients and outpatients. There, excuse me, there are a number of elements to the program that are designed to increase access to dental services for patients, both financial and non-financial. Financially, we charge our patients a very minimal amount of money. We charge per appointment, not per service. So a 45-minute appointment is charged at $40. And many of our patients are covered under social services, so that they don't pay at all. So we make our services as financially accessible to people as possible. One example of non-financial barriers that we overcome are people who don't speak English as a first language. We have access to translators who can meet the patient and come with them to the clinic to help make the appointment go better. So we're very focused on the barriers, and we're very focused on finding ways to overcome them. We've accumulated donations from the hospital and from outside the hospital for patients who need work, more complex work that might need lab fees, crowns, bridges, maybe dentures, that we can cover the cost for the patients. So we're focused very much on trying to address the often very poor oral hygiene of our clients. Psychiatric patients in general overlap strongly with homeless people, and we all know in a nutshell they have very poor oral health status and they've got very low utilization of services. Some of the other elements of the program are that we try to overcome stigma associated with mental illness. So all of our staff are trained in anti-stigma behavior. All of our staff are aware of the episodic nature of mental illness, and that when our clients come in different moods, we know how to adapt, but we're very much focused on the person and on looking at oral health as one very important element in the recovery of patients who are struggling with mental illness. The other element is we educate dental students to be better prepared to provide services. So students start in their third year, and right through to their fourth year, they come to CAMH and they do clinical rotations. So it's not an observership. It's not something where they're just watching and taking notes. They're actually thrown right into the deep end. They're there. They're doing all the treatment that we would do under the supervision of staff dentists. So we focus on things that we want the students to pay attention to the patient, not to the tooth. So we educate them beforehand to the patient's condition, to the treatments, to the mental health diagnosis, and what we can do to help make the student a little more aware of how their behavior must sync with the patient's treatment. We found after about 5 or 6 years that we needed more. The students asked for more. It was not quite enough. So about 3 years ago, I started a course at the dental school called Psychiatry and Dentistry. It's a 6-lecture course that students get in third year, and it prepares them for the rotations. It takes them from, there's 5 guest lectures and myself, so it takes them from common mental illnesses to anti-stigma training to history of psychiatric services in Canada, past, present, and future, to trauma-informed care and a number of other things. So it gives the students a lot more didactic support. So when they come to CAMH, they understand a little deeper what schizophrenia is. They understand a little deeper what the side effects of the medications are. So they can not just focus on the patient with the perceived behavior, but where the behavior came from, what the treatment has helped and not helped the patient with, and all the other elements to psychiatric care. We also try to form very strong partnerships within the hospital with the other healthcare workers, psychiatrists, social workers, physicians, and the others, which helps us get our work done far more effectively than if we didn't have this connection. So for example, with every new patient that I see, I read all their hospital records in the EHR, the electronic health record. So I know what their diagnosis is, I know what their issues are, and I can prepare myself with, which the next slide will tell you about. And finally, we try to publish the findings of our rotations, of our programs, so that they can encourage and support other dental schools in Canada to hopefully try to incorporate psychiatry more into their work. This is just one example of a patient that I saw maybe 2 years ago, a 28-year-old woman recently arrived from a war-torn country. When I read the psychiatrist's notes, I found out that the woman had suffered immense trauma, where her infant son and her husband were killed before her eyes by the military, and then she herself was repeatedly raped, and she was suffering from post-traumatic stress disorder. And I had to somehow find a way to connect with this severely traumatized person But knowing this before she came, I could give some thought to how I could adapt my behaviors to be more especially welcoming, less threatening, more helpful, all these things along the way. And the appointment went well, and I'm convinced to this day that it would have been different. It may have gone okay, but it would have been different if I hadn't had an understanding of what her the nature of her post-traumatic stress disorder was. So having an understanding of the psychiatric conditions, the patient's behavior. I have one patient who is known for pulling hair. So I can prepare the students, I can prepare myself. So the collaborations within the hospital allow oral health to be seen by the other practitioners, the physicians in particular, as a vital, vital program in the recovery of patients. The second example I'm going to talk about is TAAAC, Toronto Addis Ababa Academic Collaboration. TAAAC is a multifaceted program. It's the University of Toronto's largest global health program in partnership with Addis Ababa University. And TAAAC includes about a dozen different realms. So there's mostly resident training at the medical level. So there's physicians who are specialists training radiologists in the Addis Ababa University medical residency program, surgeons who are there, there are emergency physicians, family physicians, there are also nurses and speech pathologists, and dentistry. So dentistry is a big part of the TAAAC program. It was brought on later than the others, but it's now become a vital part, and it's seen within the Addis Ababa University and the U of T Global Health Program as a part of providing comprehensive education in partnership with Addis Ababa. This woman in the middle is a fourth-year dental student a number of years ago, pre-COVID, who is teaching the Ethiopian dental students how to place amalgams. I go every year and I take at least 2 dental students and often another professor, and we teach. We're capacity building. As you can see here, the partnership brings together faculty and learners at U of T and AAU, and together we're preparing professionals to meet Ethiopia's needs. So we're not at all there to provide service. We're there to work with them on their perceived areas of weakness to help strengthen their programs in medical and dental education so that they can become the next trainers, and eventually they're going to be doing all the training in the dental school and the medical school. So some of our specific goals are broaden the skill set of graduating dental students who will then be placed rurally, and they can offer a wider range of services to Ethiopians. And we have an oral surgery resident teaching program now, and an example of that is to provide oral surgery training in Noma surgery. So ultimately, we're there to build capacity in educators to make Ethiopian dentists trained to become the future trainers in dentistry. And last but not least is the Toronto dental students who are in 4th year, and it gives them access to global health. And many of them after become interested in global health. They may not devote their career to it, but they have this understanding of how much we can do with our skill set in Canada. So we're training a cadre of dentists, new grads, who are coming into the workforce with an interest in partnerships and working globally. The third example is the NAG project. The NAG project stands for Noma Action Group. This group was formed about a year and a half ago. In 1986 to 1989, as I said, I worked in Mozambique. In 1987, I unfortunately saw the first child that I ever saw with Noma. And it was in the hospital in Beira, and I was brought in, and the nurse introduced me to this child sitting on an examining table, and he had a huge bandage wrapped around his face. It was almost akin to a towel. I had known about Noma, I had prepared for Noma, but nothing prepared me for what I saw when the bandage was unwrapped. It stuck with me, as many people who've seen cases of Noma say, it cuts to the core of your humanity. I didn't do much right away, and it just always rattled around in the back of my mind, why am I not doing anything about this? About 7 years ago, when I was asked to lead up the TAAAC program, and I got back into global health after a bit of a gap, I started to go back to my time in Mozambique. I started writing about it, I started reflecting on it, and I started presenting about it. That's when I got more interested in my experiences with Noma. I wrote an article, and I collaborated with Claire Janté, who provided images. The article was published, and that led to us showing the film Restoring Dignity at Our Dental School. It was the Canadian premiere, and from that, myself and the students who worked with me had this idea: we want this to continue. We don't want to just show the film, which, by the way, had 252 registrants. We want to make the work go on. So we created this group called NAG, or the Noma Action Group, at the Faculty of Dentistry. The only group of its kind that I know of in Canada. And the goals that we set for ourselves are advocacy, particularly for inclusion of Noma as an NTD. One example is we've just written a letter to Canada's Chief Dental Officer to help work with him to prepare him to be able to speak to the WHO when this proposal, hopefully in the near future, comes forward to include Noma as an NTD. Awareness building. In our knowledge, the awareness about Noma in dentists and doctors in Canada is extremely low. So showing the movie was one thing. We've published some articles about Noma, and we started another project called 1 Hour for Noma, where we're working with all dental schools in Canada so that each school will incorporate a mandatory 1 hour lecture about Noma. So to overcome the lack of awareness, every dental student in Canada would then graduate with a 1 hour comprehensive lecture about Noma. We've already started in Toronto. We're trying to get it going in other dental schools. The last is education. We want to educate ourselves so that we become as knowledgeable as possible. We had Fidel Strub, a Noma survivor, speak to our NAG group last month, and we have coming up in the new year Dr. David Shea, who's a surgeon, who's done a lot of Noma surgery in Sokoto, will speak to us about Noma surgery. The fourth project, Marianne, if I'm coming to the end, please give me I don't have a timer in front of me, please give me a nod to finish up, please. The fourth project is a homeless oral health project. I worked for 12 years at the Queen West Community Health Center, and I was in charge of the dental program. When I started, there were very little services geared towards the homeless. We all know, as I said before, the homeless oral health situation is not very good. So it's a program located in downtown Toronto where there's very many homeless people and homeless programs. So we started to brainstorm how we could reach out and bring people who were homeless into our program. Our program served the community, but our priority to bring in more to the program were the homeless. So we started weekly outreach visits to do dental exams in drop-ins, community centers, and slowly over time we started seeing a vast increase in homeless people who came to the dental clinic. We worked with the other community health centers, our multi-sectorial places, doctors, dentists, nurses, social workers, all work together to reach the complex communities that they try to serve. So we worked with them to coordinate our work. We started to advocate to improve services for the homeless. We brought in dental students who would come and do the exams in the outreach centers. We developed all kinds of resources. I'll talk about that in a minute. And we did some research to provide data to help policymakers make better decisions for the homeless. By and large, we tried to connect the dental issues to the broader health and social issues. Two projects I want to highlight are, one is a literacy brochure. We did a bunch of research and we found that there were very few brochures written in what's called CLAD, clear language and design. We found absolutely none in North America that were written along the lines of very good literacy principles. So we decided we would write one. We did a lot of field testing with low literacy skilled adults. In our research, we found that 1 in 6 Canadians had difficulty reading, and 38% of Canadian dentists in the office see people who may not be able to read the health information they provide. So there was clearly a need for this. So it took us 2 years to develop these brochures. The people in the images were all patients of mine. They were the end users, and we managed to get a grant, and we produced 25,000 brochures in French and English and distributed them across Canada. I worked in partnership with a specialist in clear language and design, and it won one award. It was a wonderful example of partnership with dentistry and other areas, reaching the needs of the clients who need it, and also a broad outcome. We distributed these in community health centers, in friendship centers, in public health, in dental schools, hygiene colleges. We just distributed them absolutely everywhere. The other example I want to talk about is advocacy. We were advocating for improvement of dental services for homeless in community health centers in the province for many, many years, and these are just some examples. One great example is the welfare dental services were drastically cut by the City of Toronto from $13 million to $2 million overnight. So it had an enormous impact on homeless people getting their teeth fixed. And it was done as a cost-saving measure. We did a research project and we presented it to City Hall. And eventually the end result was we managed, with the support of the media, to get the commissioner to agree that they cut it to save money. And we basically embarrassed the staff at the city for how they did this and for all the people who really lost their services. And it led to a reinstatement, not entirely, but to some of the services. So the Queen West Community Health Centre was very, very involved in advocacy at many levels. Coming to the end here, the last example I want to talk about is the Mozambique Oral Health Training Center. I spent almost 3 years in Mozambique. What attracted me to Mozambique was 1975, the Frelimo government became the independent government after the Mozambican Revolution, and they set out to nationalize a lot of services, education, health, and they had great strides. Then the Civil War took over. I went there particularly to be involved in the rebuilding of the oral health program for the entire country. I did many things. I worked in the hospital, I worked in an outpatient clinic, but I was involved in setting up the National Oral Health Training Center, which was basically closed at the time shortly after independence, about 5 years after independence, to prepare a new training. So it was set to reopen in the early 1990s after an absence. And there was no dental school in Mozambique. There is no dental school in Mozambique. The training was geared towards mid-level dental workers, what are called agents de stomatologia and technicos de stomatologia. So part of my involvement was to prepare Mozambicans as faculty so they would run the school, they would plan the curriculum, and they would plan it according to the needs of the country. So the school opened, and to the best of my knowledge, I've lost touch with a lot of Mozambique. It continued to train the mid-level health workers who were placed rurally across the country and did most of the basic dentistry that was needed. An emphasis in the program and training was on collaboration. We worked strongly with the MCH programs, maternal child health programs, with nursing programs, with medical school programs to try and broaden our reach and try and make our teams as multidisciplinary as possible. Coming to the end, some of my conclusions are many experiences with oral health care being left out of general health care are both universal and global. You see it everywhere around the globe. I remember hearing many years ago that oral health is the last to be funded and the first to be cut. And that always stuck with me. Often it takes endorsement from decision makers to draw attention. One great example is before and after the oral health resolution that the WHO passed earlier this year. I remember going to a Noma conference. There were very few dentists. The most recent Noma conference, which took place about a month ago, there were so many more dentists. My guess would be that now that Noma and oral health has been put into the resolution, there's a lot more interest in the oral health community, which is absolutely amazing. Very few examples that I know of that include universal health coverage for oral health. Focus must be on prevention because treatment is so costly and prevention is so essential in resource-deprived situations. And we know that recognition and neglecting of oral health can be very costly. Noma is the greatest example, 90% mortality rate. Emphasis also must be on capacity building. I won't be involved in any projects globally that doesn't have an almost exclusive or strong emphasis on capacity building. And constant reminders to other healthcare workers that oral health is health, and please don't forget us. And I'm always on the hunt for partnerships with other health workers to educate them about oral health, because together we work much better. I just wanted to give you a really cold and snowy thank you from Canada for the presentation. If you have any questions, please, I'm happy to answer them or in the chat. Thank you so much for listening.
Joel, thank you so much. Not at all. We really enjoyed that presentation. I think it was great to start off with kind of some very concrete examples of reaching out really based on oral health to neglected, marginalized communities. A lot of the things that you highlighted in your programs actually are very common to neglected tropical diseases, whether it be stigma, mental health, mental ill health, trauma that you've described, also just reaching out to those marginalized communities. How do we do that in terms of health communication to patients, but also advocacy on a municipal or even national or international level? So you really kind of included all that. That was really nice to see throughout all your 5 really impressive programs. And thank you for sort of setting the scene for us in that sense. There were a couple questions for you, Joel, but you mentioned you've put your students and kind of capacity building for dentistry at the heart of your presentation, and I know you literally have to run back to your students as well.
I can probably answer a few quick questions, Marianne.
Yeah, well, there was
if the others don't mind, if you want to just quickly field them, and I'll try and give quick answers.
Well, perhaps we'll just take one question. There were a couple from Stephen, and maybe, Joel, if you have time to answer in the chat, that would be great. There's a nice question here from Semu Adeniyi. Hi, Semu. Semu's works at the Sokoto hospital, the Children's Noma Hospital, and he picked up on your initiative of the 1 hour for Noma. Semu says this will be helpful in sub-Saharan Africa in containing Noma if it can be practicalized. So would you have any kind of advice or insight or thoughts on how something like that could be scaled out across many countries, actually?
Well, coincidentally, last Thursday morning, I gave my 1 hour for Noma talk to the dental students at Addis Ababa University. I am happy to share my PowerPoint because I don't feel it's mine. I borrowed from many people, including Yuka, and I put together what I think is a fairly comprehensive 1 hour lecture about Noma. And I'm happy to share it with anybody. I'm happy if anybody, for example, Semu wants, I'm happy to link up and give the lecture anywhere, anyhow. So whatever works for them, I would be thrilled to participate in that. So please, my email can be made available if it's not here from Marianne, but I'd love to collaborate, and if it can be helpful, I'm thrilled to do so.
Wonderful, and thank you. And I will pop your email with your permission in the chat in a few moments.
Yeah.
Well, thank you very much, Joel. We've had a few questions in the meantime from the audience. So one kind of 2 very different questions that came up in the chat, but they both center a little bit on the community. So a question from B.R. Garan, who was referring to the One Health and the Fit for School model that you described, Habib. BR says this approach is beautiful. How can it be adopted in settings where community uptakes can be challenging? And in a way, I feel that question also perhaps applies to Noma, where the first port of call is perhaps traditionally the local healer, or not necessarily a very clinical medical facility, provided there even is one. So in both cases, how do you feel would be, we talk about advocacy, and often what springs to mind is the high level, but what about advocacy to communities to really prioritize oral health, or to prioritize when they sense there's a symptom of something like Noma, to reach out to have the right reflexes?
I think it's, this question can be answered in many ways. I think one of the key things is people need to be empowered to take action. And oftentimes people feel powerless and feel paralyzed by the sheer amount of problems that they are facing, or by real or perceived technical difficulties that a certain approach or technical innovation might pose to them, it is important that you start with where you are. You need to start with little doable steps, and this is really a circular or stepwise process. You try to improve a little bit, you see the effects of that, and then you are in a better place to address the next step. So when you look at the components of the Fit for School program, for example, there's no need to start with everything right at the beginning. Of course, WASH and availability of water and soap and facilities are fundamental prerequisites. So that's probably a natural start. But then if you start with hand washing first and try to establish some routines, that is a good next step, perhaps. And then once that is available and functioning, next is to go with a toothbrushing element. And then you link up with a local health center that perhaps has tried some deworming but wasn't very successful. So then you can offer the school as a venue to improve on that. So it's the stepwise nature. It's the small doable steps. And these small achievements instill in people a sense of joy, of accomplishment, in the classic sense, empowerment. There are ways how you can incentivize that, which is another way to make things happen. Can be done through monitoring, self-evaluation, can also be done by rewarding, by competitions, by ratings, by rankings, all sorts of things. Can also be done systemically and through the institution. So if a teacher in a school says, well, I have enough to do, why should I invest in looking after WASH? Well, make sure that the WASH as an activity area or school health is part of the job description of the teacher and is part of the appraisal system. So when there is an annual appraisal and a salary raise is in discussion, if the teacher performed well in organizing a daily hand washing program, of course that is an incentive for the teacher to engage in that. And so you have to develop a network of systems, of incentives, of little nudges that help to advance the agenda and to make real change at the level. Because not everyone reacts to the same things. So I do things because I believe in a cause. Someone else does it because, I don't know, kids are smelling, and if they are clean, it's more pleasurable to work with them. A third one may say, well, the parents are more happy because the children complain less about diarrhea. So there are different incentives and different reasons why people engage in certain activities.
Fantastic, thank you. Yuka, would you like to add to this?
Yeah, because Marianne, you already mentioning about like a community engagement issue. Therefore, from that perspective, I'd like to answer your question. So as you mentioned that actually, as you know that the first entry point of Noma, maybe not health professional, maybe traditional healer, or maybe like a more, the community health worker. Therefore, as I mentioned that as a part of a regional oral health as a part of a regional Noma control program and also national Noma control program, one of the strategic objectives is actually try to train the community person to support them to raise awareness of Noma as well as early detect of Noma. Therefore, it is quite important for the involvement of the community for education and also early detection of Noma. The another point is actually, as I understand that community involvement is quite important, but we need to, establish the, framework or system how we can involve the community for this Noma activity. Therefore, maybe like in the planning process of the national or like a regional or sub-national Noma control program, it is good to involve the community worker for this, like a planning process or like a evaluation process or implementation process. The another component is as a part of the community, we also need to think about like a patient involvement, because especially Noma is really, like a fatal disease and also really, stigmatized that patient, even the patient is surviving and also even they get like a treatment. Some like a facial, disfigurement actually related to stigma. Therefore, this kind of like a survivor of Noma can be great advocate for the Noma raising awareness as well as, promoting and then like controlling Noma issues. I hope I answer your question. Over to you, Marianne.
No, absolutely. Thank you. And yeah, these are kind of questions that are relevant, you know, whether it's oral health, whether it's a lot of misunderstood diseases. So that's been really useful. Thank you very much. A figure which really stood out from one of Habib's slides, I'm sure you'll agree, is the complete imbalance between the burden of oral ill health and at the same time the number of professionals in this field. The numbers are completely disjointed in terms of regions of the world. And so there were two questions here from Stephen Brema that are kind of around capacity building in that field. And it's really interesting to have the views of a dentist, but also we're very lucky to have WHO present here. And so Stephen's asking, what types of support is WHO giving to developing nations to tackle oral health? And at the same time, Stephen also asks or suggests, have you thought of scholarships or some kind of scheme for dental students from developing nations who can go back and extend training to other dentistry students in their respective nations? So I suppose there's kind of looking at ways in which to increase that number of dental professionals in the regions, in the areas where the burden is highest.
Yuka, do you want to go first? Or
I will provide a general information in terms of how we support member states in terms of the acceleration of oral health agenda. So firstly, we actually provide some of the strategic, direction, such as, as Professor Habib mentioned, that we developed like a, global oral health strategy. We also have a regional oral health strategy, as well as the upcoming global action plan. That kind of like a strategic direction can help member states to develop their own oral health policy or strategy at the country level. The another component is actually, we also train, especially the focal point of oral health. We call chief dental officer for the capacity building, how to, progress of the oral health promotion and prevention at the country level. Another point is we also provided, a lot of technical guidance documents, such as in African region, we have a promoting oral health in Africa in 2016. Actually, these include a lot of barriers, cost-effective intervention, and also as Professor Habib mentioned that WHO now development of like a best buy intervention, that is a cost effectiveness intervention that also can guide the country to implement their national oral health plan at the country level. The another component, because actually we are doing many work, therefore, for example, we also support country for the surveillance of the disease situation. For example, because as mentioned that we have a really face lack of a disease, therefore we try to encourage country to integrate oral health indicator into the existing surveillance systems, such as WHO NTD step survey or district health information system, etc., etc. So maybe I stop at this moment. Then Habib, in case if you have additional comments, please feel free to provide. Over to you.
Thank you, Yuka. There's hardly anything left to say for me. You covered it all. I think what we need to keep in mind is also when we think of oral healthcare, we think of the oral healthcare that we know from our high income settings, like an expensive dental environment with machinery, with technology, which needs electricity, running water, lots of maintenance, lots of rules and regulations that ensure safety for patients and quality of care. But this type of care is not suitable for all settings and for all environments. And particularly in low-income countries and resource-poor settings, it is just impossible to set up a dental clinic as we know it. So we need to think about different ways of addressing the disease burden. And the one side is that we focus more on prevention, because all oral diseases are preventable, more or less preventable, with very simple and cost-effective measures. And second, we have interventions that can cover the most essential priority needs that do not require a dentist or an oral health professional there. It can be integrated in primary healthcare, performed by any primary healthcare personnel that had a little bit of additional training. So that is a way to expand coverage and to broaden access to populations that currently have no access.
This is really interesting. And in fact, you reminded me that's a question I asked myself earlier today. We had a session on WASH in healthcare facilities. We heard that about half of the healthcare facilities in low-income countries don't have suitable water infrastructure, and 70% of them don't have suitable waste disposal. And it really made me wonder, thinking about this oral health session, exactly what you said. I imagine a visit to the dentist, in a very kind of typical way, and I wondered, how does that work in resource-poor areas when you are trying to increase uptake of oral health? So thank you, that was really useful. I suppose to conclude the session, so we're in our 8th year now of this ISNTD Water meeting. I think we do have quite a captive audience across WASH, across NTDs. I can confirm that as a sector, we are guilty that although there's been great work bringing WASH and NTDs together, the WA part has certainly been attended to, the sanitation as well, particularly when it comes to helminth infections and so forth. Water and safe water has been really important for trachoma control, for example. But within hygiene, there is not really a mention, or the partners from the oral health field are not there yet. And so this is really important to us. This is very close to our hearts. So to conclude the session, what would your message or perhaps your final words be to the NTD community listening together, but also perhaps some of the WASH colleagues who are very keen to put a health consideration at the core of their work rather than an afterthought?
Yuka goes first.
Quite a big question.
Okay, you have a more thinking time rather than me. So, thank you very much. I don't have much words, but as you know, that the new NTD roadmap actually shifting, 3 dimensions. More impacted oriented, more cross-cutting approach, and also more, programmatic and also ownership country action. And then definitely, everything is quite important, but especially cross-cutting point, because as mentioned that the Noma is quite, I talk about Noma issue, a lot of a similarity with Noma and NTD. And also, as you know, that Noma also would be linked with water and hygiene sanitation. Therefore, my message for NTD community and WASH community is please remind about Noma, and then please try to integrate Noma into WASH or NTD activity, especially at the operational level. And then political level, hopefully Noma will be integrated into the NTD list, and then that will facilitate us more easily for collaboration at the operational level too. But hopefully NTD community and WASH community, please integrate Noma into your activity. That is my last comment. Over to you, Professor Habib.
Thank you, Yuka. I would just your statement, Noma with oral health, and then we are settled. I think we need to think more in systems than in silos, and in disciplines or in activity areas of research fields. If we think in systems, we realize very quickly how interconnected everything is. And if we put the patient at the center and the needs of the patient and of people, then we discover that the patient, people do not care about specialities or research fields, or whether that water tap or this toilet was constructed by an engineer or by a health professional or by an education person who cares about WASH. The main thing is that this facility there is usable, it's clean, and it's a pleasure to use. So I think system thinking is what we need, and I'm more and more convinced that the One Health concept is a very viable way of bringing this together. It could maybe even in future be enlarged into these bigger concepts of planetary health, which involve also climate change and resilience and many, many other things. And in these big pictures, of course, you fear that as a small disease group or small area, you get lost and you lose visibility. But in fact, you gain more allies, as we see here, which actually work towards the overall goal of creating a better world for everyone.
That is a wonderful concept to end on, really to kind of bring all these health efforts together. You're right, not just at the level of a patient or a disease, but really in a planetary consideration. That's really important. And thank you for inspiring us. Thank you for sharing with us the example of the Fit for School approach, which is beautiful in its simplicity, but at the same time, it's a very practical combination of oral health and WASH and NTD control. That's something that I think will stick with us. To reassure you, Yuka, I think everyone says once you've heard of Noma, you can never forget Noma. So I'm sure we've got a lot more advocates that were made and forged here tonight after hearing your talk. And also we really look forward. This is just the start of a really exciting, important conversation. It's been a pleasure to learn so much from both of you and from Joel, who is probably stood now at the lectern and training the future of oral health as we speak. So I've personally learned so much. I've really enjoyed this session, and it was a wonderful pleasure meeting you, Dr. Habib, and seeing you again, Yuka, and we look forward to seeing you very soon again. A very big thank you as well to our attendees. Thank you for tuning in at what is quite a late time in the day, but some issues are too urgent to wait, so we had to fit it in today. So thank you very much, and we hope to see you very soon again.